in Rome.
Thank you for a kind introduction. I would like to thank ASHRAE for the invitation and for giving me the opportunity to launch today in this unique occasion during our annual meeting, the new guideline on unexplained infertility. The title of my lecture already unveils the challenge underpinning our idea to provide guidance for diagnosing and treating an unexplained condition. These are the conflict of interest of our working group. In the first line, there are minds. And this is our agenda today. I will start showing you the methodology we followed for building the guideline. Then I will unveil the definition, a new definition, which is proposed by the GDG for unexplained infertility. And then the hot topic, the recommendation for diagnosis, and finally the summary. Let's start. Well, today it's a very exciting moment for me because it marks the end of a long journey. We started this journey in Vienna in 2019 thanks to an idea by Sesh Sunkara, who proposed this topic, unexplained infertility. We had a meeting. We selected our guideline development group from different SIGs because it needed to be multidisciplinary in this area. Then we had a problem I'm sure you are aware of. All the process was slowing down. We were forced to have several online meetings, and you know how less efficient they are compared with the face-to-face meeting. Finally, we had an in-person meeting for formulating the recommendation, and then we discussed the recommendation. We received several feedbacks from stakeholders. Most of them were incorporated in the new version, and now we are happy to say that the guideline is out and published on the ASHRAE website. Difficulties apart, it has been a fantastic journey thanks to the crew I had the privilege to chair. I would have loved to have all of you in our meetings room just to let you breathe the atmosphere of constructive dialogue, competence, professionalism I enjoyed. And a special tribute is due to Nathalie Leclerc from the ASHRAE Central Office for a tireless work and commitment to complete this project. This was our methodology, which sticks to the manual for guideline development released by ASHRAE. We started with the literature search for evidence of what? Evidence of efficacy and evidence of safety for patients. We then built the evidence table. We assessed the quality of the papers, and then we formulated the recommendation based on the opinion of the GDG, of these experts, and taking into account the patient perspective. We had a representative member from Fertility Europe to assist our work. Just to recall what you will find on the recommendation, first of all, the quality of evidence, all the circle, according to the grade system, it can be high, moderate, low, or very low. And I would like also to recall you that even if there is an explicit link between evidence and a clinical recommendation, of course, the clinical recommendation is released after evaluating other aspects, not only scientific and clinical evidence, which of course take precedence over the expert's judgment. We consider patient values, we consider the ratio between benefit and harms, acceptability, cost, the appropriate use of resources, feasibility, and equity. So based on the answer we give to all these questions, for example, are the desirable effects large relative to the undesirable effect, and what is the overall quality of evidence, what are the patient values, and so on, the recommendation will be strong or conditional. So now, please imagine you are in your hospital, in your private office, wherever, and a couple sits in front of you to understand why they are not fertile. Let's start from definition. This is the new definition by Ashray. Unexplained infertility is defined as a condition of infertility in couples with adequate coital frequency, and this is the first novelty in our definition to define adequate coital frequency. The couple is composed of a female partner with apparently normal ovarian function, fallopian tube, uterus, cervix, and pelvis. Second novelty, aged 40 or less. And a male partner with apparently normal testicular function, genitourinary anatomy, and a normal ejaculate. This is similar, but a little different from the ICMART definition, because we added the concept of adequate coital frequency and the age for the female partner. However, like in the ICMART definition, couples should have at least 12 months of regular unprotected intercourse before investigations are initiated. So we are in line with the other definition. Why we decided to mention female age? We look at the literature, and in particular to some mathematical models. This was elaborated by Professor Somigliana some years ago, and it documented that the false positive diagnosis of unexplained infertility under the age of 35 is just in 10% of cases, while it occurs in more than 80% of cases in women aged 40 or more. So it means that 80% of women aged 40 or more could be diagnosed with unexplained infertility in an incorrect manner and could be exposed to unnecessary treatments. Here we are with the recommendation. First step in your office, in your hospital, or wherever, is to take your time to collect throughout medical, reproductive, and sexual history for both the male and female partner. You can see there are so many things to clarify just talking with your couples. Then the first PICO questions, which is the reliability and convenience of methods to confirm regular ovulation. The first things to rule out is that the ovaries does not produce the oocyte. We have a GPP, a good practice point, because you can't believe there are no studies really documenting that a regular menstrual cycle means regular ovulation. In women with regular menstrual cycle, tests for confirmation of ovulation are not routinely recommended. Again, if we want to warrant regular ovulation, we can use whatever among urinary LH measurement, ultrasound monitoring, or mid-luteal phase progesterone measurement. Just to be precise, because it was a comment by the stakeholders, we refer to the FIGO definition of normal menstrual cycle. This is indicated in this slide, so cycle between 24 and 38 days with a little variation, intercycle variation. We tried to assess yesterday at the Journal Club session some young doctors and also Edgardo Somigliana proposed research for finding a marker of oocyte corpus luteum quality. At this stage of our knowledge, unfortunately, we don't have it. And so we should avoid to measure unnecessarily, for example, mid-luteal serum progesterone. Why? Because there are no studies documenting a minimum mid-luteal serum progesterone required for the occurrence of a spontaneous pregnancy. We are talking about diagnosis. Endometrial biopsy is not recommended in these patients to document a normal secretory transformation of the endometrium as well, and it is invasive, it is not reproducible, and so on. So we released a strong recommendation against. PICO question: should one or more tests of ovarian reserve be included in the diagnostic workup? The answer is no. In women with regular menstrual cycle, ovarian reserve test is not required to identify the etiology of infertility. And these tests, as we know, are unable to predict spontaneous conception over the subsequent 6 to 12 months. And as long as these women maintain regular menstrual function, women with a decreased reserve, determined by MH, antral follicular count, clomiphene citrate challenge test, and so on, will have the same chance of conceiving like other women from the control population. What is the accuracy? Let's go to the tubes. What is the accuracy of commonly used tests for tubal patency? Well, both ICOSI and HIFOSI, as well as hysterosalpingography, are considered valid tests for tubal patency compared to laparoscopy and chromoperturbation. And this is a strong recommendation. As a GPP, we discussed a lot on the comparison, the studies comparing hysterosalpingography and ICOSI, and we concluded that the selection of the technique will depend upon the preference of both the clinician and the patient. There is some room for a non-invasive method, which is chlamydia antibiotic testing for tubal patency. We know that anti-chlamydia antibodies persist in the serum for at least 10 years. So this test, in particular, if the lab adopt ELISA method, will discriminate between women at a high risk for tubal pathology and women at low risk for tubal pathology. I would like to just to spoil us something for treatment in place of Batti regarding the use of water-soluble contrast medium compared with oil-soluble contrast medium. Oil-soluble contrast medium is related to a slight increase of possible risk of intravasation. However, it seems more efficient as a mechanical treatment of tubal occlusion, not severe tubal occlusion. So patients must be counseled about it, and both the clinicians and the patient has to decide what contrast medium to use. In patients at a high risk for tubal abnormality, as a good practice point, direct visualization of the tubes could be necessary by laparoscopy. However, if we ask if laparoscopy is necessary before labeling a couple as affected by unexplained infertility, the answer is no. Routine diagnostic laparoscopy is not recommended for the diagnosis of unexplained infertility. And this is a scenario, this is changing as all the complexity of our ultrasound machines increases, and the possibility to detect and also our expertise is increasing. So laparoscopy should be reserved for women with abnormal tuber patency test or those at risk like after a PID or an ectopic pregnancy or with high chlamydia antibodies and so on. Let's move to the uterine factor. Which diagnostic procedures should be performed to confirm a normal uterine structure or anatomy? Normal uterine wall, normal uterine myometrium. These are the keywords we insert in the literature search. Ultrasound, preferably 3D. It seems to be superior compared with 2D. Of course, it depends on the setting and on the viability of a 3D machine. It's recommended to exclude uterine anomalies in women with unexplained infertility to make diagnosis of unexplained infertility. Which additional diagnostic procedure should be performed to confirm an anatomically normal uterine cavity? None. I'm sure you can look, you can see what is hidden here. If ultrasound assessment of the uterine cavity is normal, no further evaluation is needed. Okay, I will reveal it in hysteroscopy. It was proven that hysteroscopy may diagnose little polyps which are not seen at the ultrasound, and little adhesions, septa. However, this not change the management, does not change the prognosis of the patients based on the available evidence. Finally, for the women, cervical and vaginal factors, another things I would like to have hidden is the postcoital test. We released a strong recommendation against the postcoital test, which is subjective, poorly reproducible, inconvenient to the patient, really change the clinical management, and does not predict inability to conceive. As far as vaginal microbiota testing, which is a current fashion now, we should consider it just for research purposes, because nothing is ascertained about the diversity group of vaginal microbiota. Let's move to the male part. Basically, the GDG recommends at least one basic semen examination according to WHO criteria 6th edition, performed by a lab which subscribes an external quality control program. If this first examination turns out normal, in the absence of anatomical alteration, in the absence of something in the history, nothing more is necessary. But if the results from the first basic semen analysis is below the lower 5th percentile, we have to repeat 3 months after. Should men undergo additional diagnostic procedure to confirm normal genitourinary anatomy beyond the physical examination? The answer regarding testicular imaging is no, is not recommended when semen analysis is normal. Is there any added value of additional tests in the male with normal WHO semen analysis? Are you ready? Anti-sperm antibodies, sperm DNA fragmentation, sperm chromatin condensation test, sperm aneuploidy screening, serum hormonal testing, HPV testing of semen, microbiology testing of semen are not recommended when semen analysis according to WHO criteria is normal, and they are all strong recommendations. Overall, based on the fact that for those we didn't find any evidence, any studies which met the criteria to be included in our guidelines. We can discuss, if you want, regarding DNA fragmentation. I know it's a hot topic, however, there is no agreement on the preferred methodology, on how to manage patients, and so on. For the couple, should there be additional evaluation of possible systemic causes, autoimmunity, testing for anti-sperm antibodies is in serum of either males or females is outdated and is not recommended. Testing for celiac disease in women with unexplained infertility can be considered overall for the consequences on the general health. Testing for thyroid antibodies and other autoimmune conditions in women with unexplained infertility is not recommended. What about thyroid hormones? As a GPP, a good practice point, TSH measurement in accordance with the Endocrine Society is considered good practice in every woman in their preconception care. But no additional thyroid evaluation is recommended if TSH is within the normal range. Sorry?
Speed up.
8 minutes, or there is a problem with my timer, okay? There are really the last 2 slides. Very fast. Sorry, too fast. Too fast. Testing for thrombophilia in women with unexplained infertility is not recommended based on the cost and the possible benefits. As far as oxidative stress regards, in the semen of males, should consider in the context of research. I know another topic, most of works are published on treatments with several compounds. In women is not recommended. Genetic or genomic tests are currently not recommended, and this is a strong recommendation as the difference between women, couple affected by unexplained infertility and the general population is 0. Vitamin D seems not to have a role in the context of unexplained infertility. Prolactin is not recommended, while BMI evaluation again is considered good practice in preconception care. So, dear Chairman, I finished with the summary. You will find it in the guideline. So, from the female side, menstrual history is enough to confirm regular ovulation. To confirm normal uterine cavity and structure, please proceed with an ultrasound, preferably 3D. We can verify patency of the tubes with icosi, aphosi, hysterosalpingography, and chlamydia antibodies testing plus history. And for the male, a normal semen analysis according to WHO criteria may be sufficient to make diagnosis of unexplained infertility. This is my email for any feedback. Thank you for your attention.
Thank you for a great guideline, and thank you for the talk. Questions?
Hi, Gulam Bahadur, UK. Thank you for a very good update. Now, some areas, there are very few publications and very poor quality publications. Does that really constitute as evidence to make a strong recommendation?
As I show in the beginning of my talk, a strong recommendation is based on evidence, but on other considerations. Sometimes in the absence of good quality studies, there are some harms in terms of stress, finance, and everything for patients, for tests which are quite common in the routine clinical practice of centers worldwide. So we decide to be brave and to give a strong recommendation against.
Thank you for your presentation. I just was wondering, for those male additional tests that hadn't studies, should that be GPPs instead of recommendations?
Methodologically not. We can give recommendation for the same reason of the other colleagues which made the first question. We can give recommendations in absence of good quality studies if we consider it harmful or can deviate the management of the couples, yes. It is possible under the methodological point of view, according to the ASHRAE manual.
Thank you. May I ask one question, Daniela? So, Nikos Polizos from the Xeros University Hospital in Barcelona. So, I have seen the definition, adequate coital frequency, which is a little hazy, very politically correct, but it's a little difficult. And secondly, did I miss it, or there is no duration of how long? I missed it. It was 12 months?
12 months.
12 months.
12 months.
Maybe I missed it. So.
As far as your first question regards, it was, you won't believe, one of the most discussed topics in this diagnosis, how to define adequate coital frequency. And again, we had to refer to the only studies on around 220 couples with an explained fertility, differentiating the couples having sexual intercourses every day, every 2 days, every 3 days. As a resultant, the adequate coital frequency is every 2 to 3 days. However, we decided to state it in a narrative form in the guidelines and not to include it in the recommendation, because we received some feedbacks regarding the stress that can be generated in a couple. They are prescribed to have sex every 2 days, depends on the age, on the history, and so we removed it from the text of the recommendation.
Great argumentation, I think.
And we have a question from one of the web-based listeners. It's Raymond Lee. If we decide to go forward with IVF in a woman because of age, would a tubal test be still recommended to confirm whether her infertility is unexplained?
Well, under the age of 40, and this is the definition, there are no evidence that a woman should go directly to IVF without investigating her tubes.
But